Hey everyone, this is Mike Shin from Woundwise, bringing you a brief introduction to wound care. This will be the first in our lecture series and also the framework by which we will be approaching this broad multidisciplinary field. As such, we will be covering a lot of different topics. Feel free to pause and rewind if needed, but we will be delving more deeply into the various topics covered today in this talk. Wound care is something that's been fundamental to medicine since its early beginnings. But despite this fact, we healthcare providers often get very little education in regards to it. I don't know if this is because wounds are not as often visible or as coveted as they once were, but they remained a tremendous strain on our health system today. This slide is not to bore you with statistics, but simply to emphasize that wounds are a big problem today and will be an even bigger problem in the future as it affects the elderly, typically disproportionately. A wound is one that is defined as a disruption of normal anatomic structure and/or function that is typically inclusive of the skin. You can categorize wounds based on chronicity, depth, and etiology. The skin is broken down into three different layers. You have your epidermis and dermis. This correlates to a stage 2 pressure ulcer. The wounds are pink, painful, and heal by reepithelialization. The third layer is the hypodermis, which correlates to a stage 3 pressure ulcer. The wounds are yellow, less painful, and heal by granulation and contraction. On the chronicity side, an acute wound is one that heals in an expected time frame. The cause is transient and usually lacks any significant impediments to healing, and the healing is sustained. Chronic wounds, on the other hand, are slow to failed healing, have ongoing systemic and local impediments, and unless you address the underlying causes, the wounds tend not to heal or reoccur. Now, this is the meat of our talk and is a very basic standardized framework to assess wounds and will also be the skeleton to subsequent talks. Wounds are often described and taught by their primary etiology, as many you might know, such as arterial ulcers, venous ulcers, and pressure ulcers. And although good for education and practice, this can be somewhat deceptive as it implies a singular cause, therefore a singular treatment, when in truth, most chronic wounds are a multi-system failure where although there may be a primary cause, there are multiple contributing factors and require one to assess, identify, and optimize all deficiencies until you reach a certain critical mass to healing. The first topic in this will be perfusion. And again, just as a note, all subsequent lectures will be delving much deeper into these various topics that we will briefly touch on today. Blood flow is vital for cellular proliferation, intracellular processes, healing, fighting infections, and the absence of the above functions may lead to serious infections and need for amputations. To me, wound care is a lot like gardening, and in regards to perfusion, it's a lot like a irrigation system, and it correlates pretty well. Where you have a blockage in one pipe, everything downstream kind of dries out and doesn't grow, and that's kind of similar what happens to patients' wounds, where you have gangrene or wounds that just don't heal. Strangely, when we first started, a lot of people said, who cares, if there's a patient with a significant wound, osteomyelitis, peripheral artery disease, why not just amputate, let them move on. Although amputations can be life-saving outside of those extreme situations, the reason why one should avoid amputation at all costs is that the mortality secondary to a chronic wound is pretty staggering. The mortality is greater than a 5-year mortality of many cancers, and it is not because these patients are sicker. It's an independent risk factor when risk stratified. But why is that? When these patients pass, it's not due to sepsis of the surgical wound. It's predominantly from cardiovascular events, and I think it's a very similar mechanism by which mortality goes high, such as in patients with hip fractures. And really, it comes down to the fact that the patients just stop moving and struggle with rehabilitating, typically due to their advanced age, and as such, the slowing of the circulation sets them up for cardiovascular events. Once you have finished your thorough evaluation of the patients, there are a multitude of indications, but can be summed up by indications based on the history and physical, the American Heart and Cardiology Associations, typical risk factors. And one pro tip, anytime you see a patient with a deep or extensive lower extremity wound, getting vascular screening is often a good idea, especially if they turn out to having osteomyelitis, as identifying peripheral artery disease after the fact that you've given them 6 weeks of IV antibiotics is typically a little bit of a um, complicated issue on trying to determine what to do. And so once you've determined the need for imaging, there are various modalities. The RTO duplex is the test of choice because it's cheap and non-invasive. However, it is heavily operator dependent. CTAs are good for pursuing or identifying proximal blockages. MRAs, you can look for osteomyelitis at the same time. And angiography is the gold standard because it also provides the most detail as well as the opportunity for intervention. Once you've completed your imaging, there's a concept called angiosomes that has come up in the past 2 decades, and it's akin to dermatomes, which is that certain arteries perfuse certain regions of the extremity. Therefore, if you have a blockage and the wound falls into the artery's angiosome, it usually means that there's a high probability that the patient could benefit from intervention. Once you've identified a potential candidate, patients will need consultation from a wound center, interventional cardiologist, interventional radiologist, and/or vascular surgeon. And the treatment will depend on the location, extent, and risk-benefit profile. The next topic has to do with debridement. Debridement is the act of removing excess bioburden from the wound beds. This bioburden includes dead tissue, senescent cells, and bacteria, and is based on 2 premises. Wound healing is either delayed or prevented in the presence of devitalized or contaminated tissue, and as a corollary, you must remove this to get appropriate healing. And going back to the gardening analogy, it's the way that I describe to my patients is a lot like taking the weeds out of the garden. Now you have 5 different modalities. You have autolytic, which is your body just innately dissolves it; enzymatic, using things such as collagenase; mechanical, wet to dry; biologic, using maggots; and surgical, which is using sharp objects. Simple debridement, though, is often insufficient, especially if there is undermining or tunneling. Oftentimes what ends up happening is that you end up having scarring, maintaining these undermining and tunnels open, or oftentimes you will find hidden treasures. This is an example of a patient who probably had an abscess that just didn't close, and you can see that the opening is small, but the base is big, and after several weeks, if it's not closing in, then it's probably in your best interest to having to go and open it up. And these are 2 examples of opening up a tunnel at the bottom of a foot, as well as unroofing some undermining. Now, there are some contraindications. Some patients need to just simply go to the OR for the debridement if it's extensive or the location is dangerous, such as having close proximity to major arteries or nerves. When the patients have ischemic ulcers, such as dry or stable eschars, when they have not been revascularized, typically in a ischemic wounds, the wound will not heal and cannot fight infection. And if you have a dry, sterile eschar covering it, unroofing it will only expose deeper structures, not to heal or fight infections. The exception to removing these eschars or gangrene is when these are infected or after revascularizations. And thirdly, the last is pyoderma gangrenosum, which is an autoimmune disorder that tends to induce even further necrosis when you do sharp debridement or any type of agitation to the wound. The next topic has to do with infections. The relationship between failing wounds and microbes is pretty complex and often debated. There's 2 schools of thought. One is that there's a failure dependent on a single organism. Therefore, you want to capture the culture from the wound base, which is after the debridement and which is at the interface between live and dead tissue. The other school of thought is that the failure is dependent on a synergy of various bacteria. Therefore, capturing a more superficial culture is important to be able to capture all the various bacteria that's colonizing or infecting the wound. The truth is, it probably lies somewhere in between, but, we tend to start with trying to capture the culture after the debridement. And then if there's any other bacteria that grows on that culture, to try to treat all of those. And as many of you know, the culture and sensitivity will guide the antibiotic choices. Now, where antibiotics and or the infection and the debridement part comes together is that necrotic tissue is dead by definition and does not bleed. And if you remember the mantra from surgery, how do you know when to stop debriding? It's you debride it till it bleeds. Antibiotics will only go where there is blood flow and therefore stops at the interface between live and dead tissue. So, for example, in this example, if all of that dead tissue is infected, your antibiotics, because there is no blood flow through it, will not penetrate. And as such, it is paramount that to attain source control, you must debride and remove all of the infected tissue. This is another example, a patient who unfortunately has what looks like necrotizing soft tissue infection, and you see that the infection has become so bad that it has gone and just necrosed all of this tissue. And as you can see, although there is no tourniquet, all of the debridement is resulting in effectively no bleeding. And so if all of that tissue is truly infected, and that there's no chance that the antibiotics are being efficacious. And so, necrotizing soft tissue infection is a spectrum that is typically inclusive of necrotizing cellulitis, fasciitis, and gas gangrene. You should consider this diagnosis in patients with white blood cell counts greater than 20,000. They're septic, and for some, you can pursue a Larinic score to risk stratify. Anytime you see a hemorrhagic bulla, ecchymosis, crepitations, and or gas on imaging, these are indicative of necrotizing soft tissue infection. But by physical exam, I would say ecchymosis and hemorrhagic bulla are some of the hallmarks that I look for, because what that indicates to me is that the infection is so bad that it is going through dissolving not only tissue, but also dissolving blood vessels, which is being released and coming to surface. The treatment is often surgery, antibiotics, toxin mitigation, and if your facilities allow, plus or minus hyperbarics. Osteomyelitis is another infection that is critical in identifying and treating appropriately in wound care. The wounds typically will not heal with underlying osteomyelitis. A positive probe to bone is osteomyelitis until proven otherwise. And it is really critical, if possible, to differentiate between acute versus chronic, because acute osteomyelitis means that typically that the bone is still alive, and after 6 weeks of IV antibiotics, the infection should be resolved. Chronic osteomyelitis, on the other hand, is indicative of necrotic bone, meaning dead bone. And going back to the debridement side, if the tissue is dead, there is no vasculature. Therefore, if you have IV antibiotics, it will not penetrate, and as such, surgical resection is the first line of treatment. The next topic has to do with edema. There are many, many reasons people have edema, but the daily fluctuations of edema is devastating to wounds as it tears it and often results in a lot of drainage. In addition, just the dilution of the oxygen, and if they're infected, the antibiotics, as well as the compartment pressure that prevents appropriate flow of blood and antibiotics with unmitigated edema is often devastating. And, it's a lot like when you look at balloons, whenever you have skin under pressure, it just doesn't take much trauma to tear it open. And, with all of that internal pressure, the skin's natural recoil is to rip open. Now, there are several ways to address edema. There's diuretics and host optimization, such as if they have uncontrolled congestive heart failure, elevation. Ideally, you want to elevate the leg above the affected limb above the heart. You can have compression, which will be dosed upon utilizing an ABI typically. When you do use compressions, you have these are the three common modalities we tend to use, which is compression stockings, which can be ordered, 3 to 4 layer wrapping, as well as tubey grip. Now, the next topic has to do with dressings, and unfortunately, there is no topic that is more confusing as well as fear provoking in providers. And I think a lot of this has to do with, the last thing a provider wants to feel is not knowing what you don't know. And the truth is, it's a lot simpler than most people think of it. However, I do want to start that, most dressings, for all of the various ways that it can optimize the healing and fighting infections, to be honest, the data really hasn't proven out. And, when you think of it from a different perspective, I think it'll make sense because, the dressing is only the dressing. It is a band-aid. And, you have to realize that the band-aid is not going to reverse ischemia. It's not going to reverse malnutrition. It's not going to reverse offloading. It's not going to reverse edema. It's not going to reverse all of these things that we will talk about today. And if you think of it from that perspective, you realize that the value of dressings and the potential for them to actually address the underlying causes is really low. So I would say that, in terms of the power of benefit in terms of wound care, I think dressings are important in terms of more style points. There are situations that it can be critical, but truth be told, it really is the icing on the cake, and you must address the underlying causes. However, there's nothing more important for the patient's lifestyle. If the patient is wet all the time, if they're staining their clothes, staining their bed, they repel their family, they're embarrassed to go out, these patients are not going to like you very much, and they're not going to think you're very smart. For that reason, they may never come back. And so, in terms of lifestyle and the patient's compliance, and as well as their sense of participating and having some degree of control over their care, there is absolutely nothing more paramount. However, the endpoints or the benefits and the rationale are for two very different things, although it does come together in the end. And so, to some degree, you must be proficient in regards to the various dressings. But the general idea is that, you want to match the dressing to the amount of drainage that's being produced. You don't want it too wet. You don't want it too dry. You want it just right. So for heavily draining wounds, which is the one area that, if you don't address the drainage appropriately, the wound can get worse and be damaged. And so in these cases, we tend to use foam, ABD pads, sometimes wound vacs. But at the same time, you must address the underlying cause for heavy drainage. In these situations, when patients have heavy drainage, it usually means that they have things such as unmitigated edema, ongoing infection, or ongoing repetitive trauma. And the dressing is really a bridge until you can address those underlying causes. Whenever you have mild to moderate drainage, you can use alginates, hydrofibers, and some of these alginates will be impregnated with silver, honey, calcium, and so forth. If there's light drainage, you can use gels, Silvadene, Tegaderm, hydrocolloids. And just a note, if you are to use topical antibiotics, consider the timeline. and the amount of drainage. If there's a lot of drainage, then you probably don't want to use a um, petroleum-based cream or antibiotic, because if you cover it with a piece of gauze, then you will cause an occlusive dressing. And at the same time, if you're using a topical antibiotic, if it's for a chronic wound and it's going to go on for weeks to months, they will probably develop a resistance. So in those cases, we recommend that you try to utilize antiseptics such as betadine, Dakins, and Silvadene. The next topic has to do with optimizing tissue growth. Malnutrition is often the biggest contributor to failed wound healing and is found in so many of our patients, especially those that come to wound centers. 30 to 50% of acutely hospitalized are malnourished, 50% of long term care, and 85% of nursing home patients. Malnutrition results in an inability to fight infections, produce vital proteins, and eventually leads to the breakdown of vital organs, including the skin. Heavily draining wounds can lose up to 30 grams a day. And, for some patients, for these elderly patients, they are behind a 4-ounce steak every day in terms of protein, trying to catch up just to get to baseline. We have various nutritional markers. We'll often use albumin and prealbumin. And I like to look at albumin and prealbumin a lot like finger sticks and A1Cs. The albumin has a long half-life and the prealbumin has a short half-life. And so, for example, I'll take a prealbumin, I'll initiate treatment, and then I'll check their prealbumin again in a week later to see what the effects are. And so another similar series of blood tests that we often use are CRP and ESR, where CRP can rise pretty quickly and drop pretty quickly and helps track the response to treatment. Once you've identified malnutrition, you should try to increase protein intake by diet and supplements. Some patients will require feeding tubes, and in rare cases, IV nutrition. But just be conscientious that for whatever supplement you give, you must be conscientious of their comorbidities. Therefore, the various elements that are contained within the supplements that you choose. And so, for example, for diabetics, we might choose Glucerna, renal insufficiency, Nepro. If you're in a facility, you can get Beni protein, which is basically pure protein without the elements. And at home, you can get things such as Isopure powder. This topic has, this is kind of the Miracle-Gro topics. And so hyperbarics, synthetic grafts, and negative pressure wound therapy. And I think these things are very powerful. Oh, sorry, I've gone too far. But, I just do want to emphasize that this is not something that you typically start at. For example, if you have a garden and the entire irrigation system is busted, there's weeds everywhere, there's an infestation, the topography is all messed up, the ground is completely dried out, your first instinct is not going to be Miracle-Gro. You realize that you're going to have to address the underlying fundamentals, and then if your garden isn't growing, then you'll pursue Miracle-Gro. And I would say that the body and wounds is very similar. These are not the first line of treatment. The next topic has to do with biomechanics. Offloading. In any wound that is regularly subjected to pressure, offloading is paramount. Pressure will induce local ischemia, and donuts is thought that oftentimes whenever, if it's surrounding an ulcer, it can amplify the ischemia as people's skin and tissues sink in. And it's a lot like stomping. The way I describe it to my patients is that it's a lot like stomping their garden. If you stomp your garden every day, it doesn't matter how great your gardener is, there's really nothing you can do. But really, the true mechanism of pressure is that it doesn't take much to blanch your skin. And when that skin is blanched, what ends up happening is that the blood isn't flowing. If there's no blood flow, then the skin is basically ischemic, and at some point the skin dies. And again, as you can see, when you push on your own finger, it doesn't take much. And as such, you can see that, there's a multitude of different types of pressure ulcers, from very trivial pressure that various medical devices can cause. Classic pressures, on the other hand, typically occurs in the debilitated, paralyzed, and weak. In these cases, you must address stool, urine, and secretions aggressively. Malnutrition is a common compounding factor, and oftentimes these patients need specialty mattresses. And what this does is that, going back to that cap refill, it doesn't, what happens is that it helps the skin blanch a little bit more pink when it alternates, or it doesn't let your skin blanch completely white. And in the worst case scenario, some patients may need surgery. Moisture is absolutely devastating to many wounds. It can lead to maceration, new and worsening of wounds, and just general poor wound healing. For stool, urine, and secretions, you must address them appropriately. For stool, you do diapers, stool bulking, rectal tubes, and in severe cases, diverting colostomies. Most often, whenever there's a significant impediment to healing, or there is ongoing osteomyelitis with a high probability of contamination. Some patients may need a temporary or permanent Foley, suprapubic catheters, and in young females, you might want to consider contraceptives. You should also consider zinc oxide paste, barrier sprays, and in some situations, wound vacs are very helpful to controlling and protecting areas from moisture. Patients with wounds on the lower extremities, we will often use total contact casts, prosthetics, felt pads, and wheelchairs. And again, going back to the blanching of the skin, if a patient has a wound on the bottom of their foot and they're standing on it the whole time, that skin is going to be blanched, and the likelihood of it healing from the pressure-induced cutaneous ischemia is pretty low, but it is even lower when they continue to just stomp on it. In some situations where wounds overlie joints, it's critical to immobilize it. And in some cases, we will go all out and use total contact casts, cam boot walkers, various joint immobilizers. Lastly, you should be generous with analgesics, especially in the patients with some form of ischemia. That sympathetic tone can amplify the ischemia, make the pain as well as the healing potential worse. And lastly, you should try to optimize host factors. If patients have diabetes, for example, and they have an A1C of 20, regardless of what you do, the likelihood of healing is probably pretty minimal. And with that, that will conclude our introduction to wound care. Please stick around and look for the subsequent lectures that we will be putting up. They will go much more in depth to all of these various topics that I've covered today. And if you have any questions, please feel free to reach out through email, and we'll be happy to get back to you. Thank you.